for having webinars, series of webinars on the topic, which perhaps not as a medical professional person, but even the part of society will like to know the latest about it. And of course, double helical is a very established messaging of 10 years now, and which has been covering all the topics for the information and in the interest of society for medical profession. And I appreciate efforts of all, including the main brain behind it, Mr. Amrish Tiwari. Now, today's topic is revisit COVID. Of course, I have many experts in front of me, and as regard the viral fever is concerned, ever since I was born, I'm hearing इसको वायरल फीवर हो गया, उसको वायरल फीवर हो गया है। उससे पहले का भी पूरा हिस्ट्री है, लेकिन ये जो 2020, the COVID-19, which came to India in March 2020, and now it is more than 5 years and 3 months. I think this particular COVID word has created a very, very unique history in the medical science, an absolute impact in the mind of the people of this universe. We had COVID in 2020, we had COVID in 2021, and those 2 years were of, in my opinion, that of course, as medical profession, we may like to know and try to understand medically, but a normal person will not like to remember those days. It's the black days in the history of humankind. Then there was dilution, and then it 22, but every time with some sort of 23, 24. But this 25, again, we are hearing the fact is the COVID is back. COVID is back. A perception, lot of information. And when we get too much of information, there is some sort of fear in the mind of the public. So our aim is that today we will like to discuss what is this in 2025. The COVID is scientifically, from the microbiological point of view, public health point of view, clinical point of view. So I would like to start and request Dr. Banerjee. Dr. Banerjee, you have been the part of discussion and you have mastered as regard this particular topic is concerned. First of all, I would like you to tell us that this 2025 COVID, the clinically, what is the presentation and in what way it is different than others. We have been joined by Dr. Sunila Garg. Dr. Amitabh Banerjee is the person belonging to medicine and public health, and he is from T.Y. Patil Institute of Medical Sciences, Pune, a totally dedicated researcher. So, Dr. Banerjee, will you like to tell us about the clinical pattern of COVID of 2025?
Well, thank you, sir. Thank you, Dr. Agarwal. Thanks, everyone, for attending. And yeah, this is actually the surge started from Southeast Asia region. It started Singapore, Thailand, Malaysia, Hong Kong, and then India. So these subvariants, these are subvariants or you can say sub variants of Omicron, which came almost 3 years back. And I remember Dr. Sanjay Rai saying that Omicron will act as a nature's vaccine, because the Omicron onwards it became milder and milder, but more transmissible. Number of cases were more and milder and milder. And subsequently, JN1 came last year, also couple of years back. It did not make much of an impact in our country. Now we have got the sub variants LF.7 and NB1.8.1 or Nimbus. So this is detected now. This has become more or less a dominant variant. 30% cases not only in other parts of Southeast Asia, even in USA, but this is causing mostly upper respiratory, some sort of pain in the throat. We can say just as like a knife in the throat, but it is not causing a large number of hospitalization or deaths. It has been a co-infection with people who are with comorbidities. So mostly there have been deaths also. There have been about 50, 60 deaths, maybe about little under 100 over the past month or so. But these deaths are in people who are having comorbidities. So as on today, this is, I wouldn't say it is of much clinical consequence per se, standalone. Standalone, it is not causing much of an impact, but we have to take care. It gives a message that we have to have health services to follow, say, treat the comorbidities, treat the hypertension, treat the diabetes, treat the obesity, prevent the obesity. And that is the way to attack it now. Focus on the comorbidities rather than on the virus. So I think this is my take on it, sir.
So you want to say that from public point of view, it is a variation of Omicron, and as a part of public, I will like to know, should I worry about it?
I wouldn't worry if I am healthy, I am not having comorbidities. And even if I am having comorbidities, I would rather be worried about treating my basic comorbidity, my primary disease. So I
Okay.
am sure if I can control my primary disease, if I control my, and this has been the story right from the first wave. Particularly data from USA came, the maximum mortality were among the blacks, and they found that most of them were hypertensive without access to their treatment for hypertension, without access for treatment diabetes. So this has been the story from the very beginning, and of course the earlier variants were slightly more virulent, and the story continues. And today, it is just a incidental finding in a person who is dying of some other cause, because these sub variants, the more lighter they are, the more benign they are more transmissible. They spread very far. So large proportions of the population will be harboring the this variant, and incidentally they are tested, so they may not be related to the death at all. In fact, certification of death also got distorted. In the beginning it was all right because we wanted to chase the virus, but in certification of death, anyone with a COVID positive or RT-PCR positive has been, cause of death is being labeled as COVID, which is incorrect as far the death certification is concerned. It may just be a other incidental finding. So now we should go back to our conventional death certification. We should go back to a conventional case definition instead of any asymptomatic incidental finding and labeling it a case. So we should now go back to what was since ages, or since classification of a case or death certification.
Thank you. Thank you, Professor Banerjee. Professor Sanjay Rai,
Yes, sir.
the, the, the senior professor of community medicine and All India Institute of Medical Sciences, having vast experience of dealing so many things, but as regard COVID is concerned, perhaps you have the because minds कहते हैं ना, mine of knowledge, big mind.
Thank you, sir.
जैसे राजस्थान में मार्बल की माइंस हैं, तो आपके पास कोविड के नॉलेज की माइंस है. What had been your impression, and especially as regard the your experience of 2025 COVID, uh, in comparison to the clinical care being rendered at All India Institute of Medical Sciences. We'd like to throw light on it.
Thank you, sir. It's a really very important question. And thank you, everybody. Namaskar, all the panelists, Dr. Arun, sir. See, the COVID, the first time appeared or originated from a lab, I don't know, but all the circumstantial evidences indicating it's originated from a lab in December 2019.
That's
Since then, it's almost more than 5 years, almost 5.5 year old virus, SARS-CoV-2, which is causing COVID-19. Sir, if you recall, in June 2020, Dr. Amitabh Banerjee was also part of that statement. We made a statement that now we should learn to live with the COVID. COVID will be here, and that time lockdown was implemented in this country with the aim. If you recall, the official presentation was made by officers in a press conference that through lockdown by 16th of May 2020, we will eliminate this disease. This was the version. And that time you mentioned you cannot eliminate this. Now, kindly learn to live with this virus. So it's in 2025, it's not a new virus, it's the same virus with definitely it's a new variant. And this new variant, JN.1, is also not a very new variant, almost originated 1.5 years ago. Very highly transmissible, as Dr. Amitabh Banerjee mentioned. So if a highly transmissible virus is there, that may infect the population. But if the population is completely susceptible, if there is a immunity gap, definitely any virus can create some problem. See, what are the evidences we have? And we should speak only based on the evidences.
Yes.
We have not vaccinated children less than 12 years of age in this country, whereas US, even 6 months and above, they have vaccinated everybody with the 4th dose. and the 4th dose was against this Gen.1. So in August 2024, FDA approved this Gen.1 vaccine against Gen.1, and the CDC recommended that everybody above 6 months of age must get this vaccine before the winter. They inoculated. We have not inoculated even less than 12 years, not a single dose. Why? They are not causing any problem because there is no immunity gap. These are the evidences. So the strength of modern medicine is evidence-based medicine. So we have evidence that if see the second wave, almost the infection rate was around 50%. So 50% population was susceptible that time. And the Delta wave, that was a Delta wave, April and May 2021. Within a month, it reached to 4 lakh cases per day in this country, and that was the reported cases in the month and April and May. And then suddenly there was a drop. So gradual, it was not a gradual drop for 6-7 months. So sudden there was a drop. And why this happened? Because of everybody got infection, almost majority of population. When we did the sero survey in Delhi after the second wave, we found that almost more than 80%, even children 5 to 10 years, they were positive. Seropositivity was even more than 80% in that. So when everybody was saying that there will be a third wave and that will create a problem for the children, officially we gave a statement that no, we don't have any evidence that third wave is going to create a problem in children, and this happened. So currently, I fully agree with Dr. Amitabh Banerjee. There is no need to panic. This virus was there even in the 2023, 2024, 25, and this will remain there for many years. We don't know. Even for next 50 years, this will be there. So I don't think that there is any evidence that there is a immunity gap. If immunity gap is there, definitely. Same virus, the Omicron virus, is a mild in nature, highly infectious, either JN1 or any other subvariant of JN1 in the circulation in this country also. So I don't think that there is need of any panic.
Thank you, Sanjay. One more question to you.
Yeah.
That what had been the experience in All India Institute of Medical Sciences in last 2-3 months clinically about the patient reporting? I'm not talking about the outdoor reporting, but say indoor serious cases, intensive care, because perhaps All India Institute reflects the tertiary care experience of the country.
Yes, sir.
We
See,
understand that, of course, and as Professor Banerjee said, it's mild, but it's only the comorbidities which is perhaps affecting the individual in more serious manner.
sir, we have not seen any sudden rise in the hospitalization or severity. And see, this virus causing problem in those who are with the various comorbidities. No, I don't agree with this statement also. See, if the background infection rate is suppose 1%, those who are dying with any disease, either with accident or even terminally ill, dying like cancer patient, and with the background infection rate is 1%, and if you test during post-mortem after an accident, and if that person is a COVID positive, 1% of these, all the accident even will be the COVID positive. All the deaths will be the COVID positive. So you cannot say they are dying from the COVID. They are dying with the COVID, we can say. Okay. So there is a there is a huge difference between dying from the COVID and dying with the COVID. All these deaths are currently almost dying with the COVID, not dying from the COVID. And we have not seen, sir, any sudden increase in the hospitalization, etc. Yeah.
Thank you, Sanjay. I appreciate one of the very important messages what you gave is number one, this that it is dying due to COVID or with COVID. And I believe this is a very important message which has been given by Dr. Banerjee also, that if somebody has got serious complications, serious comorbidities, the progression of that particular disease is there, which may be the cause of mortality, but somehow the person is COVID positive also. So let us treat
Sir,
that.
can I come in? Sir, can I come
Yes,
in?
yes, Sunila.
Yeah, I just wanted to make sure that whether I'm audible and all that, and then so
Very
that
well,
because I'm
very
You are
well.
audible, you are audible, ma'am.
yeah. Thank you so much.
Very well audible.
Thank you.
And
And now,
welcome.
nowadays, Sunila, a woman is more audible.
No, it's all everybody's. So I can see only one woman is there among so many men, so that's okay. Okay, sir. Hanji.
Please,
You can
I'll
carry
come
on.
back to you, Sunila.
Sure,
And number
sure.
two message, what you said, Sanjay, that those who suffered in 2021, the worst period of COVID, and somehow at the end of those peak, rest of the public of India became seropositive. That means they developed immunity.
Yeah.
And I was just thinking, look, and in that episode, many of our friends, colleagues, relations, they left the world.
Yeah.
That is unfortunate, but जाते जाते वो दूसरों के लिए एक ऐसी स्ट्रेंथ छोड़ गए
That
कि
is our
उसके बाद हम लोग रिलैक्स हो गए.
Yes, sir. That was
of
very
this.
devastating.
It's a very emotional feeling, I will like to say,
Yeah.
कि वो तो चले गए लेकिन हमारे लिए एक ऐसी स्टैंड छोड़ गए, and which perhaps we appreciate that. डॉक्टर के मदन गोपाल साहब, मैं आपसे बात करूंगा. We all know our friend, our colleague, Dr. Madan Gopal, who had contributed as advisor to Niti Ayog. And along with Niti Ayog, now I always say the institution which is the think tank of the health ministry, the institution National Health System Resource Center. And all the policy making and everything, education, training program is being regulated. So Dr. Madan Gopal, after hearing Dr. Banerjee and Dr. Sanjay Rai, I will like to know, you are at the helm of affair for creating policy for the country, and what extra policy you can comment upon the policy of yesteryears, and what more our country is going to do, because एक बार जब वेव आती है तो पब्लिक तो हिल जाती है ना, पब्लिक तो परेशान हो जाती है. तो व्हाट इज योर say on that?
Okay, thank you, sir. Thank you, Double Helix, for this opportunity. It's a privilege to be part of these discussions because I've been hearing all the esteemed panelists since COVID times, and their stand and other things have been more or less clear, and they know that how to allay the fears which is cropping up, and they have been very instrumental in giving feelers to the community, saying that there is no need to panic. Right from I have seen Sanjay ji from since the first wave, second wave, they have been coming to the TV saying that no need to panic. But that was the thing. As you have rightly mentioned that our seniors who have left, they have given a strength to us. So that's another thing we should recognize. But recognizing that when during the COVID time, when I have closely watched how the things have shaped up during the first wave, when we started with the testing at the airports and we started banning travelers coming from the particular sections. At that time, it was a very disarray. That means the technicals, the administrations, and the others, so they were not knowing what to do. There was entirely disconnect between all the three fraternities. The administrators were not knowing what to do. The technicalities were not having the voice to influence the kind of thing which should happen as a response. But ultimately, what happened, we learned as the things evolved, we have learned, we have matured, and we have understood that okay, what kind of response is there. So COVID has taught us the importance of global health security and how the international travels and other things are going to impact in our future discussions and posts. Previously, also, we do have a system. We did have a system. The integrated disease surveillance system was there. That was going strong. And in fact, if you look at the system which was there, ICMR is having this ILI and SARI system is there. The influenza surveillance network is there. Plus, they do have the VDRL and the multidisciplinary research teams are there. Compounded with the augmented with the IDSP network, I think they are able to detect a lot of strains. Otherwise, it would have been very difficult for it. At that time, the policy decision was it has evolved, and based on the evolution, based on the evidences which were coming from this, we have calibrated our response during that time, during wave 1, wave 2. But after that, after the intense period was over, then the rethinking of preparedness started. That means we have to prepare for the peacetime also. COVID has taught us that we should always be ready. At that time, the thought process was that we have to create resources which have no regret resources. That means at that time we invested into the oxygen capacity. We do have an oxygen capacity of around uh, around 4,000, 5,000 metric tons per day. that kind of capacities we have built. It right up to the peripheral more institution, that capacity is there. We do have that testing facilities. Initially, when COVID started, we have seen that we had only one lab which was testing. Now it is tests are rapidly available. Now we say that we have to do a calibrated testing. Only testing has to happen when it is required, or one. But that kind of shift has happened into the thought process and other things. Nevertheless, if you talk about the surveillance mechanism which we are having, we at the time also we had the integrated disease surveillance system. The ICMR system was there. We are doing the same thing. We have strengthened our surveillance mechanism. That means now, instead of taking for granted whatever the parameters we have decided, we are testing all the people. That means all the fever surveillance is happening right up to a block level. All the block institutions, the community health centers, fever surveillance is happening, and that information which is coming uh, in conjunction with the efforts made by ICMR, I think that is feeded into the integrated health information platform, and that creates an intelligence. And based on the number of clustering of the cases, rapid response teams are there. We will take action on that. That's the that thing which is ongoing. That's why no need to worry from that point. The government is quite prepared. The testing capacities are enough. The preparedness mechanisms are enough. Apart from that, we are trying to create more bed capacities to take care of that. You see that the first time in the country, we had around pan-India, largest pan-India infrastructure project, which we call as PM AFIM, Pradhan Mantri Ayushman Bharat Infrastructure Mission. It's around 70,000 crore, in which we are trying to build the critical layer blocks at the district level. That means another capacity would be added, around 2 lakh beds would be added in this direction. Plus, we are trying to augment the integrated response of the laboratories which are there. Because in COVID time, we struggle to have the diagnostic tests going up to the masses, up to the village level. So what we are doing is at the block level also, block public health labs are created, which will be integrated with the integrated public health labs at the district level. Previously also, we do have public health laboratories. Now we have augmented that. Now we have made it integrated public health laboratory. That means it's not a deviation, only augmentation and strengthening of the existing mechanism which we used to have. But the response is now calibrated. Previously, it was only the health ministry now. Now anything happens, that whole government approach and the whole government thinks is also percolated. I think the moment some response comes, this kind of situation occurs, immediately the interministerial mechanism kicks in, and you might have seen the cabinet and other thing. They usually take meetings of
Yes,
the
yes.
various ministries. That kind of thing has become institutionalized. Apart from that, to keep a watch on the evolving evolving genomes, we do have an InfoGov network which was created during the COVID times, and this InfoGov network is now actively doing the or actively monitoring and carrying out the genomic sequences around the country, and they do have a network of laboratories which are in this part of the network. That means you have mentioned about the policy thing. Policies remain the same, but more intense it has happened. More whole government approach it has happened. Now the coordination between ICMR, Ministry, NCDC, it has improved. But still, a lot of work is to be there. Challenges are there to further strengthen and augment this facility. Then we do have the sentinel sites for watching at the ICMR has having around more than 20 institutions which are there, which are seeing that how the COVID people are behaving. They are following the patient for the long COVID also. So, in nutshell, I think we are having all the infrastructure in place, the policies which we used to have. That means we are trying to augment that. One of the important work which still remains uh, is enriching the epidemic act. That still work is in progress, and we are trying to see that how that can also be built in, so that during the peacetime also we can take care of the preparedness activities, so that we are ready to take care of any pandemics or any this kind of thing. Because in the coming years, the travel is not going to stop. The international travel is going to increase. The interaction between the humans and the animals are going to increase because the farming and other things is also going to increase, and that will put a challenge on how to bring all this. That's why this kind of infrastructure which had been set up after the post-pandemic time, I think that will come handy in the future, uh, future identification of any of the surges and other things. So, but lastly, one of the important thing which remains is we are creating so many infrastructure, we are generating so much information, but we have to now start seriously thinking about building capacities to analyze this data and bring it to some logical kind of thing, so that we can also generate some evidence. So otherwise, what happens? The panic which has been created recently, had it been systemic input from the NCDC side, I think this kind of panic won't be there. That kind of input should be coming in the public domain if we talk about how to allay the fears and other things. That's the only things which are work in progress. I think in future we would be seeing much from us. Thank you, sir.
Thank you, Dr. Madan Gopal. I think you correctly gave us the picture of what the entire mechanism of our government, including Health Ministry and other associated institutions, including ICMR. And as a government, all the departments are now alert. And whenever needed, they all come together. One window approach, you may call it. But there is one question in my mind, Sunila. Can I put it to you?
Yes,
You
yes.
see, 100 years back, 107 years back, we had the similar episode of Spanish flu. So that Spanish flu gave us some sort of understanding of such a vast pandemic, and we gathered some information during that time. I wish 1918 में भी हमारे पास वही रिसोर्स होते जो कि 2020 में थे, लेकिन वो रिसोर्सेज तो वहाँ नहीं थे. So what sort of information we gathered out of Spanish flu, which was useful for us in 2020, and now with this experience, what sort of information you are giving to your future experts after 10 years, 20 years, 50 years, because one never know what will come back when. It's a very
So thank
important.
you for asking. Yeah, this is a very important question, because any pandemic, when you mentioned about Spanish flu and subsequently, when we talk about Ebola and all that, outbreaks which recently have happened or Nipah virus, when we talk in Kerala, which was so very recent, every pandemic leaves a kind of a, future, I'll say, what actions have to be taken. Because you see, when we look at the current scenario also, when Dr. Madan pointed out that now we are talking of not fragmented approach, but whole of government approach, which is very, very important. So that's how we are able to, now we are thinking of surveillance part, we are thinking of monitoring part, because at that point of time, we never had a kind of a system. We had only number of cases, broad number of cases. But now we talk of, exactly in terms of surveillance and monitoring, and which is comprehensive surveillance, which is very, very important part, and where we can also, he mentioned about genomic sequencing also. That's how we are able to make out that today, cases which are of LP 8.1 are 38%, or NB 1.8.1 are 37% cases, or XFG are 8%. And we do have subvariants of Omicron like MC 10.1 or LB 1.3.1 or LF7, as was mentioned by Dr. Amitabh Banerjee. Because we, as you said, no pandemic, when we see that, we have to be always watchful. Because May 2023, we had declared, the end of public health emergency of international concern. But at the same time, we never mentioned that COVID has gone out of our lives. So that is where it is important to have system strengthening, which all our, outbreaks have taught us that it is important to have system strengthening in terms of whether we talk of leadership skills, whether we talk of capacity building, whether we talk of supply chain management, which also was pointed out by Dr. Madan Berry, that we are, talking about in terms of pandemic preparedness, mock drills. It's not only COVID. We have to be prepared for other, outbreaks also, and particularly when we talk of respiratory system outbreaks, it is always very important to focus on myths and misconceptions, because this particular outbreak also, as pointed out by Dr. Amitabh and then by Dr. Sanjay also, was that basically we got it from Sierra region and all that. And today also, now we say active cases are 5012, that means 5012, and we have discharged almost 19,453. But the important message which I say should go from this platform, apart from, the number of cases in different states and all, like with Kerala having highest number of cases and all that, state-wise monitoring and at district level monitoring is very, very important. But somewhere we need to talk about, we have never talked about adult vaccination as a whole, because most of the people whom we are losing, are because of co-infections, and people who are comorbids are mostly, vulnerable to, respiratory infections, whether we talk of tuberculosis, whether we talk of SARS-CoV-2, whether we talk of, other, like even we talk of tuberculosis as well. So that is where it is important to have kind of, particularly I say that avoid 3 C's, avoid closed environment, avoid overcrowded environment, avoid close contact, which is not only true for COVID, it is true for all infections. So this is how, when we look at overall, kind of outbreaks. So, apart from, giving all the messages and all about good respiratory hygiene and all, but it is important to look at, how we can address the issue. If we talk about 5 of us or 6 of us in this forum, how many of us are regularly taking flu vaccine? How many of us are taking pneumococcal, or, now we talk of, pneumococcal 23 strain? That is important. Now you started talking of other vaccines. Sitting in subject expert committee. Also, I will say that, basically now countries have incorporated COVID vaccine in their annual program. But people should know that now they're available on different platforms. Recently, I reviewed a proposal when we were talking of COVID vaccine through oral this thing. So it is also there. So, but important part is that every pandemic has taught us that we must address myths and misconceptions. We must focus on, diets, and particularly, when we talk of vitamin C, vitamin D, zinc, they are very, very critical. That part is important. Another thing is, as was pointed out by Dr. Madan, comprehensive surveillance and surveillance strategies are very crucial, and we cannot work in isolation. We have to work together. But data is very, very important, because if we would have complete data of Spanish flu, or, when we talk of complete data in terms of Nipah virus, now we are fairly very advanced. We are working in collaboration with NCDC, ICMR, and there is whole of government approach. Our facilities are being strengthened as per PM Abhi mission. So that part, data is very important for any of the public health responses and decision making. So that part is very, very important. So we need to look from that perception. But every time we should keep public in our mind, because they are looking forward towards us. What are the important messages we should be giving to them? System is one part which the government is taking care. But somewhere we forget that at the center is public. And whether we today also, when we talk of hand washing and all, I think somebody had put in WhatsApp and all that, we said we had hand washing day. So that becomes still very important. We talk of respiratory hygiene, not only true for COVID, but true for all the respiratory infections. When we talk of maintaining distance, it is true for all. Now, when we talk about the vaccination part and outbreak, that is left to the individual and experts. Depending on the variants in circulation, we have to be watchful, and we have to also see that whether it is going to work or not. Because when we talk at WHO level, WHO says that any vaccine which has got 50% efficacy, not only COVID, I'm talking of typhoid, I'm talking of other vaccines also. So that will give approval. But we have to see whether the vaccine is going to work or not. That part becomes very important. So I feel that this platform should also take public into consideration, and what are the key messages, they are very, very important. Thank you so much. Thank you, sir.
Thank you. Thank you, Professor Sunila. As usual, the message given by you is very, very public friendly, and that is what our aim is. And I think you said very clearly, and other colleague also said, that COVID is here to exist. In other words, I like to say each one of us is married to COVID. There is no appeal of divorce.
Yes.
Can we say
Yes.
so,
Yes.
Sanjay? हैं?
It will
कोविड के
change in
साथ
its
जीना
form.
पड़ेगा, डाइवोर्स का अपील नहीं है, हैं?
Yes. Yes.
So now with this discussion, my last discussion will be status of COVID vaccine. Every time we think about COVID vaccine with changing strain, like in a different influenza virus and all, there is different strain and the new vaccine is being prepared. What do you think? And there had been a vaccine controversy, the vaccines from outside, vaccines within India, and what we understand that our Indian vaccines became a very success story for the entire globe, right? So what do you think the future of vaccines should be? And I will like short comment from all of you. Amitabh साहब, पहले आप बताएं.
Sir, historically, sir, in the past also, corona vaccine did not last, have not been very successful because of the rapid mutations. और जैसे ही नया strain निकलता है ना, new strains are transmissible so fast. By the time you develop the vaccine, the people have already got the infection with the strain and they have got the natural updated immunity. तो
Yes.
हमको वेट एंड वॉच करना है सर, पॉपुलेशन के ऊपर डिपेंड करता है। जैसे वेस्टर्न में एल्डरली पॉपुलेशन है, 70-80 साल 90 साल के हैं, वहाँ पे शायद जरूरत होगा। जैसे अफ्रीका में अभी के जो पैंडेमिक में, इवन इन दी फर्स्ट सेकेंड वेव, अफ्रीकन कॉन्टिनेंट्स एट लेस देन 5% वैक्सीनेशन एंड दे डिड नॉट सफर मच बिकॉज ऑफ द लीनर पॉपुलेशन एंड यंगर एज. So we require more research on COVID vaccines. The present lot has not been fully, the results are not yet out. RCT, कोई भी RCT का फाइनल रिजल्ट अभी तक नहीं आया है सर, इमरजेंसी यूज में था अभी तक। जब तक रिजल्ट नहीं आया, वी कैनॉट से एनीथिंग विथ कन्विक्शन. वी रिक्वायर मोर रिसर्च.
Dr. Sanjay Rai, the future of vaccine.
The future of we are discussing COVID, so most probably
Yes, of course, in relation to COVID.
there are 37 vaccines already approved by the various regulatory authority of this world for one disease, COVID. The policy, vaccination policy is different in different country. Like earlier I mentioned, in this country, we have not vaccinated children less than 12 months of age, whereas in another country, I'm taking the name, 6 months and above, they are vaccinated with the 4 dose, right? US. So it's a time, as Dr. Sunila Garg mentioned, it's a time to compare the overall death rate in these children due to COVID. My impression is the overall death in children is more in country where they have vaccinated. So this could be because of the vaccine associated. One could be the AD, antibody dependent enhancement. See, many experts, they mentioned that, okay, in children, they are not dying with COVID, but they are dying with the this multi-system inflammatory disease syndrome. What is the multi-system inflammatory disease syndrome? It's a hyperimmune type of response 4 to 6 weeks after the COVID, right? So if COVID is not causing problem, all these vaccines are not preventing infection. If already they are infected, if you are already vaccinating, so we have sufficient evidence that vaccination will increase the immune response, right? So that will enhance your immune response. So the chances of even this multi-system inflammatory disease syndrome is more in children after the vaccination, theoretically. So it's time to analyze the data. we don't think that we have analyzed data in this way, the risk and benefit analysis of the available data. And there are countries, now we have many countries, they have vaccinated 6 year and above, 6 month and above, 12 year and above. So it's a good opportunity for us, but the whole problem is these data are not available in the public domain. So the future, more than 200 vaccines are still in the various phases of the development in the clinical trial. So, but the overall, I don't think there is any future of this vaccine. See, there is no science, sir. See why this COVID is not creating problem in our children. We have not vaccinated even with a single dose. Our government is sensitive. I believe our government is very sensitive. We supplied to vaccine to more than 70 countries. So why we have not included? Because science never supported this. Even this time, science never supported the vaccination. We never found any this immunity gap in our population. Otherwise, this highly infectious strain could cause a very severe problem. But this not happened. Just like second wave, Delta wave, within 1 or 2 months, that was very devastating. We lost many friends, sir, as you mentioned. We lost many friends, many relatives. But now that is the strength. So, and there are publications that that's not only the humoral immunity. With the natural infection, we have cellular immunity. So it's hardly matter, even if your this antibodies level are low, and if you have cellular immunity, that will take care of this. So till date, we have cellular immunity, and let's say all the evidences are indicating we have very good cellular immunity, and that's why it's highly infectious variant is not causing much problem in the population. Even the less infectious variant, they caused a lot of problem, but they are not causing problem. So I don't think that in future for COVID vaccination we have any future, at least as per the evidence science. So for some vested interest people, definitely they have a scope. So thank you very much.
मैं देख रहा हूँ कि हमारे फ्रेंड डॉक्टर मदन गोपाल, एक तो इनका जो प्लांट इनके साथ रखा हुआ है ना, वो इतना कूलनेस दे रहा है कि इनको तो दे रहा है, मुझे भी दे रहा है दूर से देखते हुए। और ये बैठे हुए प्लांट के साथ मंद मंद मुस्कुरा रहे हैं, और मुस्कुराहट के पीछे कुछ कहना चाहते हैं। Dr. Madan Gopal, what do you think with this episode of 2025 is the policy of vaccinating more versus bringing new vaccine, and that too within our Indian companies, whether it is from Hyderabad or Pune or any other company?
It's very important, very pertinent question, but the answer is very difficult to give. Because as you have seen, after 22, that after we have inoculated so many people, more than 2.2 billion doses were given, then when more and more vaccines were given emergency authorization, after that, what has happened? They told that if you want to get a vaccine jab, you go to private and get it done. And there is no push from the government for vaccination. If you go, suppose I want to take vaccination today, it will be very difficult for me to find a place where I can get a COVID vaccine.
लेकिन डॉक्टर मदन, गवर्नमेंट भी तो आप ही है ना?
नहीं मैं नहीं हूँ, आई एम जस्ट
एक्सपर्ट।
नहीं, अब देख ली द फ्यूचर में आप देखेंगे तो वायरस इज सो म्यूटेटिंग,
Yes.
the vaccine which is whatever vaccines which are there, whether that would be potent against that variant or not, we don't know. Studies are not there, and we don't know. Suppose why the Western people are making, because they are having a different technology for vaccine, mRNA technology है, that can be easily adopted for the changing variants. तो हमारा conventional जो हम लोग ने vaccine बनाया है, तो we do have brought in that technology, but where is the evidence that we require a vaccine against that particular strain? Because आज मैं vaccine का कोई strain बनाऊंगा, next year it is behaving just like an influenza. Every year you have a different strain and you have to inoculate for that. And as Sunila ji has mentioned that how many people are aware that they should be getting influenza jab every year. Very difficult because that kind of awareness is not there regarding the adult immunization. As Sanjay ji has mentioned about the children immunization, the multi-system inflammation that is caused by this. So it's a knack-whack. This Anteki has to decide कि क्या करना है उसके ऊपर आगे क्या करना है. Because for that also we require evidence. We don't, unless we have the evidence, how we are going to push for developing a vaccine. एक एग्जांपल बता रहा हूँ. When I was working with नीति आयोग at that time mpox का भी एक आया था वहां पे, monkey pox का आया था.
जी जी जी.
So then was all were pushing that we should be having vaccine, monkeypox का vaccine बनाते हैं. They started negotiating, discussing, but it was required. No. एक और चीज है जो we should have been, एक जो ग्रुप काम कर रहा था वैक्सीन एंड थेरेपेटिक्स वाला, we have focused too much on the vaccine part. Therapeutics part, we are still not able to find out the antiviral drug for this COVID. Because if we are having an antiviral drug, we are only testing with the available antiviral drugs. But have we able to bring out a therapeutics, which research हो रहा था, but we have going very slow in that. तो क्या क्या वायरस एंटीवायरल ड्रग्स हम लोग पेटेंट कर पाए, सक्सेसफुल हो पाया नहीं हो पाया. तो instead of shifting focus there, because virus is going to stay with us, as you have rightly mentioned that marriage हो गया, divorce नहीं होगा. When virus है तो उसको कैसे कम किया जा सकता है, you have to focus on the therapeutic aspects. Vaccine strains are changing every year. You should be having, just like influenza, if it is so devastating, but the effects are not that devastating. The evidence which is coming is not that devastating. Only the comorbid conditions, as Sanjay ji has mentioned, you died because of COVID or you died with COVID. So that kind of thing is there. तो इसलिए वैक्सीनेशन का उतना कोई स्कोप नहीं है सर आने वाले दिनों में. Unless and until it causes a lot of problems, lot of catastrophe, or
Thank you.
some evidence is there.
Thank you, Dr. Madan Gopal. I think, Sunila, you said correctly कि कोविड वैक्सीनेशन अपनी जगह है, but at least in adult vaccination program of India, let us concentrate on those जिसका सिस्टम पूरा तैयार है लेकिन टेकर्स बहुत कम हैं. Am I correct?
Yes,
Adult
definitely, sir.
vaccination.
Definitely. When we talk of, the
So
we
I will like you to comment in short
yeah.
about your views about vaccination, and perhaps we should again re-emphasize government to have some sort of policies that adult vaccination हम लोग अभी नेशनल प्रोग्राम में ले आए हैं या नहीं?
नहीं अभी नहीं है सर
नहीं आए हैं
प्रोग्राम
ना?
में, but we are talking, and recently there was a workshop at PGI Chandigarh on vaccinology where we had full 1 day focusing on adult vaccination, where the focus was on influenza, pneumococcal, typhoid, because there are various things, because it's not only the vaccination, it's also antimicrobial resistance. Because you see, if one is suffering from, let's say, influenza, but initially, no provider is definitely going to say that it is because of this. So people start moving from one provider to another. And even our pharmacies are potential, they are acting as potential doctors. So that's why we are also worried about antimicrobial resistance. And in this direction, ICMR is also working very closely. But also, I will say that we need to, as Dr. Sanjay, Dr. Madan, all of us have pointed out, that we need to look at the data, because all of us suffered from COVID. We also had vaccination. What played an important role? Because I remember last 2 years back, when I went to Florida, and at Sarasota Memorial Hospital, everybody was eager to know that how did 1 billion fought against COVID? Because we were one of the very few first countries with such a big population to look at, that, because at that time we had controlled our situation, but other countries had not. So we have to think of this vaccination also, because it's such a fast mutating virus, but different countries have included in their immunization schedule. But still, with all our, we need to look at our elderly population, where people, and you are also, sir, working on the same white paper as I'm associated with you on elderly care. So that should clearly talk about this part, about the adult vaccination and all that, but we also need to look at the comorbidities, because after, when we look at 70 years plus, they are going to be roughly, 4 times than that of under 5 children in due course of time. So we need to look at that part also. Sir, I have to leave. Thank you so much. I have to leave.
Ma'am, kindly sit with us. There are few questions for you. No?
So, sir, I have already got to go. I told you there has been death of a very close friend, so I have to go.
No, so you may leave. Okay, thank you.
Thank you so much. Thank you.
चलिए मैम, नमस्कार.
Thank you. Namaste. Namaste. Thank you.
Thank you, madam.
Sir, you have unmuted yourself, sir. Dr. Agarwal, sir. Sir, you have
Yes. Tiwari ji, आप सुन रहे हैं?
Yeah, it's okay.
Now you are audible,
So
sir.
now, please, I'm handing over it to you for the questions in brief,
Yes,
and
yes.
we have to finish it within 10 minutes.
Okay, sir. My first question goes to Dr. Sanjay Rai. Sir, could you tell us how do you foresee the balance between personal freedoms and public health mandates in future COVID waves?
It's a very difficult question, but okay. I shall try to answer. See, usually in public health, what we do this risk and benefit analysis, right?
Yes, sir.
Overall benefit of that particular intervention and overall risk. Like I'm just giving you example, like when the entire population was susceptible, the COVID case fatality rate, I'm not talking about the infection fatality rate, case fatality rate was around 1.5%. During the clinical trial with the original Wuhan virus, the efficacy found was around somewhere between 70% to 95%, like Pfizer messenger RNA vaccines were highly effective, almost 90%, but not from the infections. They never prevented from the infections. See, all the countries after 100% vaccination, either Singapore, South Korea, Japan, they faced major outbreaks, right? So, so they never prevented from the infections. All the major outbreaks in this country were after the vaccination. So overall, if through vaccination, if the population is susceptible, this is my calculation, almost 80 to 9% reduction. That means every million, if through COVID case fatality rate was 1.5%, that means 15,000 were dying. Vaccine were able to prevent 13 to 14,000 dying deaths in adult population, right? When the population is not susceptible, that means when they develop immunity against the virus, majority developed through the natural infections. And these natural infections most probably are long lasting, at least from severity and deaths. There are many papers, even when the WHO recommended that everybody should get vaccine, even that time we had sufficient evidence that natural infection is providing much better protection than any vaccine. Even from the infection also, these vaccines are not preventing from the infection. They are preventing from the severity and deaths when the population was susceptible. Now the population is not susceptible. But the natural infections preventing from the this infection also. So the chances of transmitting infection to other person, those who had exposure, is very low. Seeing all this, and that's why we did analysis in children also, that in children, the overall mortality, if you see the public literature available in the public domain, 2 per million, the vaccine associated deaths are much higher than 2 per million overdoses. So in adult, 15,000 were dying case fatality rate. In children, 2 were dying. So even in adult, if if you can save 13 to 14,000 life, you can sacrifice 30, 40 per million if the vaccine associated deaths, right? So there was a huge benefit of vaccination when the population was susceptible at that time, based on the data available, clinical trial data, right? But even children, even in the initial phase, even they were susceptible. Now they are not susceptible. Even if the entire children were susceptible, if the 2 million deaths were there, and if vaccine associated deaths were much higher than these two deaths, right? 30, 40 is 15 times higher. So even that time when the population was susceptible, that approach was not good. I don't know why the many other agencies they recommended, including WHO, even WHO, if you see the recommendation of today, WHO recommendation, everybody must get vaccine above 6 months of age with the new variant. So I don't think there is any hope. To the best of my understanding, they may cause more harm than the good. Thank you.
Thank you, sir. Kindly stay with us. The next question goes to Dr. Madan Gopal Saab. Sir, could you tell us how can technology like AI and predictive analysis be integrated into India public health infrastructure to combat evolving variants?
Thank you, Tiwari ji. Is a very important question because during the COVID time, we have learned how technology can be integrated into the surveillance mechanism. I will just cite examples. During the first wave, we have seen how the Arogya Setu app was used. It used a Bluetooth and triangulation technology to find out who are the persons who are exposed to that particular virus, who have come in contact with this. That means that technology is there, Arogya Setu. It has shown that how the contact tracing can happen. I think in future we will be seeing that how this app-based contact tracing can happen using this technology. That's one thing. Second thing, yeah, we have now having good portal, that is the integrated health information platform. All the data is coming. COVID has taught that the data was coming from three sources: one from ICMR, from NCDC, one from the ministry. All the three were combined at one place, and the dashboard was being created. And that we are increasingly using. If you go to the ministry, now they are having a war room for this. The observatory is there. That is restricted, and they know that what is the thing which is happening, and they are using algorithms and other thing to forecast what would be the projection, what would be the requirement, and that kind of thing is already built in. That means already we are using the this AI for forecasting and other things. In the COVID times also, based on the number of cases and other thing, that kind of tool was developed. That means what would be the requirement of the beds, what would be the requirement for oxygen. That's why the chaos which was created that could allay, because of the third wave also, so many things have happened. But we could manage because we know that epidemics usually follow. It's not that whole of the country would be experiencing an epidemic in one go. That kind of projection, that kind of thing, that kind of algorithms are already been followed and they have been structured into that. Second thing is increasingly what is happening. Data triangulation is happening with the use of this application, the AI application, other things. That still work is in progress, but increasingly you will be seeing a lot of utilization of it. That essential to say that we do have that mechanism. That means Arogya Setu was there for disease surveillance. We have perfected that. Now it is used for generating ABHA IDs also. Then with a common identifier, I think you would be having access to all the data. In fact, one of my papers, which when I was working with Niti, we have come up with a paper that means disease surveillance in 2035 by use of this digital tool using ABHA ID. And that kind of thing is how the patient electronic health record would be used for this disease surveillance, and that kind of mechanism would be there. So apart from that, during the COVID time, we have perfected the technology in the form that the EVIN platform was there. That is electronic vaccine intelligence system was there, which we have perfected, we have adopted, and we have further scaled it out as a COVID platform. And that would be increasingly used for doing the immunization and other things in the coming days. That means technology is in place, right from the digital IDs for the people, embedding the digital ID into the electronic health records, and using this electronic health records for generating intelligence and use of that intelligence for our purpose. we are trying to see that the hospitals which are there, that information also comes into this integrated health information platforms, so that the rapid response team which are there to do the outbreak containment and other things that can be activated on time and this. So increasingly technology would be seen in the coming days for disease surveillance and instituting disease this containment response and other things.
Thank you, sir. Sir, next question for Dr. Sanjay Banerjee. Sir, could you tell us how do you see the role of genomic in predicting and mitigating future outbreak of COVID-19 variants?
For me, sir, Sanjay
How do
Banerjee.
you see the role of genomics in
Uh,
predicting and mitigating future outbreaks of COVID-19 variants?
I personally think that genomic surveillance should be for academic and scientific research. It has little practical application. I'll tell the reason because for genomic surveillance to identify a new variant, the new variant should already be circulating. आप सैंपल लेंगे पॉपुलेशन से दैट मीन्स द वेरिएंट इज ऑलरेडी आउट द बॉल हैज क्रॉस द बाउंड्री लाइन तो आपने जीनोमिक सर्वेलेंस पता कर लिया बट that new variant has already spread. So uska before you identify the variant, you will see the results whether hospitalization is increasing or deaths are increasing or impact. And usually by Darwin's law, the variants become milder and milder as we have seen in this pandemic also. So genomic here, we should not waste too much time on genomic surveillance for a very mild virus. We require genomic surveillance for more serious diseases like tuberculosis and other things, where using this genomic surveillance, we can identify the multi-drug resistant strains at the beginning only and put the patient where there is a proper treatment for that. Otherwise, it is of academic interest also. I mean, that is my view. A virologist would be able to answer better.
Sir, thank you, sir. And last question goes to Dr. Arun Agrawal, sir. Sir,
Ji.
could you get me?
Yes,
Sir,
yes.
as an expert, could you tell us what are views on reintroducing mask mandates in schools and crowded public spaces given in the rise of the new variants?
ये तो क्वेश्चन बहुत इम्पोर्टेंट है और मेरे जो कम्युनिटी हेल्थ एक्सपर्ट्स हैं दे आर द बेटर पर्सन लेकिन जब आपने मुझसे पूछा है तो देखिए ये जो 2025 वाला वेरिएंट है ये तेजी से बढ़ता है और ये भी है कि इसमें इट्स हाईली इन्फेक्शियस दो द सिवियरिटी इज लेस दैट इज वाई ये आया गया वाली बात है आया और गया और माइल्ड सिम्टम्स देता है एक्सेप्ट फ्यू जहाँ की कोमॉर्बिडिटी है और उसके साथ ये कॉम्प्लिकेशन क्रिएट करता है तो जहाँ तक आइसोलेशन और मास्क की ये तो एक यूनिवर्सल प्रोटेक्शन है जो कि हमको टाइम टू टाइम जब लगता है तो जरूर यूज करनी चाहिए दैट इज व्हाट आई फील आई डोंट
एहतियात के तौर
नो ये
as a
प्रिकॉशन
एहतियात
तो हमेशा
precautions.
ही लेनी चाहिए ये मतलब तो नहीं है कि हम जानबूझ के कहें कि लाओ भाई जो भी है हमको इन्फेक्शन दो बिकॉज इट डजेंट मैटर इट इज माइल्ड तो ये प्रिकॉशन ऐसी है जो कि हम लोग स्पेशली ये मतलब नहीं और दूसरा ये भी नहीं है कि हम घर के बाहर ना निकलें इट्स नॉट दैट सीवियर सो डू योर नॉर्मल वर्क टेक प्रिकॉशंस whether it is mask or hand washing etc and be comfortable.
Okay, sir. Now over to you for conclude the webinar.
I think we had such a wonderful discussion with presence of all my uh, experts, which are not only from country level, but they have contributed even to globe. I have a wish list. You know what is my wish list? This is to you, Dr. Madan Gopal, Dr. Sanjay, and Dr. Banerjee, and to Sunila. I asked a question, what is our experience out of Spanish flu, which I understand started in 1918, right? And during that time, the experience was taken to the literatures, etc., in a minimal way. But this time, when we started having experience from a lab in 2019, December, and then it came to India in March 2020, in 5 years. And somehow, unfortunately, the suffering were big in numbers in India because of the population. हमारी पॉपुलेशन यदि ज़्यादा है तो हमारे को सफरिंग भी ज़्यादा फेस करनी पड़ेगी. तो डॉक्टर मदन गोपाल, डोंट यू थिंक वी कैन क्रिएट ए मोनोग्राम, a massive monogram at country level, which can be led by any institutions you, whether it is All India Institute or NSSRC or ICMR, and bringing all the experts together, and there should be a literature to be created not only for India, for the entire globe. एज ईएनटी सर्जन मैं ये सोचता हूँ कि ये जो हमने म्यूकर माइकोसिस का एपिसोड झेला है राइनोलॉजी में, ये हमने अभी तक इसको एक मैसेज क्यों नहीं दिया कि क्यों हुआ. डू यू थिंक दिस म्यूकर माइकोसिस विल कम बैक लाइक दिस? नो, आई विश इट नेवर कम्स बैक. So it's a responsibility of we as ENT surgeons and ophthalmic surgeons and neurosurgeons and other supporting diagnostic people should create a big monogram on mucormycosis. वो तो एक बहुत छोटी सी चीज़ है, लेकिन कोविड के बारे में तो हमारे पास जो ये है, आई होप वन कैन टेक ए लीड इन इट, a group, and to create something which will be used after 50 years, 100 years. Sanjay, do you agree with me? वरना तो हमारे बच्चों के बच्चे ये कहेंगे कि
200%
हमारे
सर.
हमारे फोर फादर्स ने हमको ठीक से गाइड नहीं किया.
ये agreed sir,
200%.
agreed sir, we should be having it. तो लेकिन
हम्म.
अभी तक नहीं हुआ. आपने बहुत अच्छा बोला है सर. मोनोग्राफ है ही नहीं
इसका
हमारे.
we tried our level best during COVID time. Almost 20 people, like Dr. Banerjee was also, almost all the head of department. Dr. Sunila Gar was also part, Rajesh Kumar from PGI. So all we created a group of 20, and all. So what we did, we released statements, official statement from the IPHA, IAPSM about the vaccination, overall COVID policy, and really all these are, there are 5 statements we released. So we tried our level best, and see, anytime we can create, Dr. Madan Gopal is there. We can sit and we can create.
That's why my job is to give my wish list.
Yeah, excellent
Yeah,
suggestion.
agreed sir. बहुत अच्छा idea है sir, because the other people, the authorities, the NDMA ने जो बनाया है, they have also made a compilation, but they have made the compilation based on their requirements. Medical fraternity के point of view से नहीं
I
बनाया
think it should be totally medical fraternity, including the entire clinical scenario,
जी.
the progression of disease, all the plus point of ours, all the minus point of ours.
जी sir.
You should not hesitate in bringing out your minus point.
नहीं सर,
So
साइंस
it is
साइंस
not
के लिए
typical.
सर, और साइंस ये बहुत ही जरूरी है सर. एंड शायद यही रीजन था कि इवन लॉट ऑफ मीडिया प्रेशर बच्चों को कोविड प्रॉब्लम क्रिएट कर रहा है, बच्चों को शिकार बना रहा है. हेडलाइंस इन ऑल मीडिया चैनल, मेनी एक्सपर्ट्स ऑन टीवी डिस्कशन कि बच्चों को जल्दी से वैक्सीन लगा दो, वैक्सीन लगा दो. दिस ग्रुप जो भी मैंने अभी नाम लिया, recommended that there is no need to vaccinate children because that is risk and benefit analysis is not in the favor of children vaccination. And thank to government of India, finally जो है वो agree हो गए. So definitely there is always a need of this type of group. So thank you sir, it's a very good
I
session.
mean, that is what I want outcome of today's discussion, that let us try. And try करने वही बात है, हमको हारना नहीं है, जीतना है.
Yeah.
ठीक है.
Absolutely,
हिम्मत
absolutely, sir.
करने वालों की कभी हार नहीं होती.
हार नहीं होती.
So with this remark, thank you very much to my all friends, Dr. Sanjay, Dr. Madan Gopal, Dr. Banerjee,
Thank you, sir.
and Dr. Sunila. She had to leave in emergency, and the entire team of Double Helical. Amrish Tiwari ji and Duggal Saab and everybody for giving us this opportunity. I hope
Thank you,
we
sir.
are able to convey some message for the society.
Thank you, sir, very much.
Okay.
All of you, welcome, and we
सभी
will
लोगों को नमस्कार
reappear after a moment. Okay, thank you very much, sir. Thank you.
Thank you, sir. Thank you.
चलिए सभी लोगों को नमस्कार
Namaskar, sir.
Namaskar.
Namaskar, sir. Namaskar.
Thank you, sir.